Today is World TB Day, and nations across the globe took some time to reflect on the disease, how it's affecting them, but also how it's affecting the entire world. South Africa is one of 30 countries identified as those responsible for 87% of the total global TB burden in 2021. The country is still listed in all three high priority categories forming part of those global hotspots. We are one of the 10 countries that have a high TB burden, a high TB HIV co-infection burden, as well as a high burden of multi-drug resistant TB, all three. Deputy President Paul Mashatile says it's concerning that stigma and discrimination still forms part of the barriers hampering the country from turning the tide against tuberculosis. Mashatile, who is also the chairperson of the South African National AIDS Council, was speaking in Rustenburg at the official World TB Day commemorative gathering. The occasion was also used to launch the country's 5th National Strategic Plan to tackle TB, HIV, and sexually transmitted infections. So, with something the Deputy President says can be beaten, why is South Africa's infection rate still so high? Why are we one of 30 countries identified as those responsible for 87% of the total global TB burden? Well, joining me in studio for this important conversation is Professor Geoffrey Setswe from the Aurum Institute of Behavioral and Social Research on TB. Prof, I mean, there's been talk, I remember in the last couple of conversations around this issue, there was talk of behavioral contributors or challenges to this, which are both societal, but in other instances, issues of survival, where people can't negotiate, things like safe sex, for example, because of their socio-economic conditions. Talk to us about those contributing factors as well.
Yeah, TB is actually both a social and behavioral disease. We may see it as a medical condition only, but there are social factors, as colleagues indicated, that it's associated with poor socio-economic environment, undernutrition. But there's also behavioral factors like smoking, like alcohol consumption. So TB has got various other things, and HIV/AIDS worsens, the TB situation. As a colleague indicated, that 60% of those with TB have got HIV, and so it is not only behavioral factors that we can attribute to the individual, but it is also social factors that we have to deal with, like poverty and undernourishment and the accessibility of alcohol and cigarettes and programs for dealing with all those social and behavioral factors. So it is not an easy program and an easy health problem where you can simply get a vaccine and get it sorted out. You need to put up a strong social program, a strong prevention program that includes, many departments like social development, health, and economic sectors.
Professor, I mean, I've had people talking about, for example, people absconding and not taking their treatment because they don't want to stay in a clinic, or in a hospital, or they will hide their sickness because living among people, is where they get their joy. They get to socialize, they get to mix with people. And in very poor areas, it's also the difference between, going to sleep having ate something. Now, the last thing you want, people are going to isolate you or keep their distance because, they know that you have TB.
Yeah, this is the sad story about the TB epidemic, that one person who has not been diagnosed and has not been put on treatment can infect 15 other people in the family, at work, in the community. And we've got a lot of interventions, the diagnostic tests that have been identified. We can do what one of my colleagues talks about, targeted universal TB testing, test everyone who comes to the clinic. We can, use urine, we can use digital chest x-rays, and the treatment has improved dramatically. The stigma that was attached to TB in the past was that you're going to be on treatment for a long time. For example, when I had TB, I was put on TB preventive therapy 25 years ago, and I was there on isoniazid or INH for 6 months. Now people are on TB preventive therapy, as my colleague said, for 3 months. Aurum and other organizations have helped to bring in treatment to that level. For those who are on drug-resistant TB, the treatment has been cut, from 18 months with drugs that were having bad side effects to just 6 months or even less, with good quality drugs and stuff like that. I think what my colleague Vuyo was talking about was that we need to get to communities. And getting to communities is that we've got the technology, we identify people, we get them at the clinic. Once we get them at the clinic, we have interventions to get what we call contact tracing. All the contacts of that person who has been identified with TB need to be rounded up, whether they're at work, they're at home, or anything. And there's also another group that we need to talk about, children. The children, we're struggling to get a lot of them if we don't implement, community-based interventions to get them. But there are also, what is called ward-based, programs to get people to support people on treatment and to get people who are contacts, to be in touch with health services, to get diagnosed, to be found, and to be put on treatment. So there's a lot of work to be done. That the technology is there, the treatments are there, the diagnostic measures are there, but working together as different sectors of society to be able to find the people, put them on treatment, support them to stay on treatment and to adhere to treatment until they get to cure. Because we've always said that TB is preventable, treatable, and curable. We don't say the same thing about HIV. We don't say the same thing about other diseases. But this one, if we work together, we can make a lot more progress.
Prof, I mean, okay, the national strategic plan is being touted as what is going to take us forward. As your organization has an experience of partnering with the government, and obviously, well, one would imagine that along the journey you are able to see where the government is lacking, or where the way the government works, the problems that Russell spoke about, and the problem that Professor Njega spoke about. There has to be a way of, because even with the best plan in the world, you are not going to deal with this problem if there's all these moving, loose parts that are not, working together.
So there are 3 elements. One, we have a good body of evidence and research on tuberculosis. We've got the diagnostics, we've got the treatments. We can do more, and I agree with you, Dr. Farid, that we can do more. But we've got the research and the tools and the evidence. We've got the policies. We've got the policies to deal with tuberculosis. But we also have got the strategic plans. And Dr. Farid indicated that our weakness is where the rubber hits the road, the implementation. And there are 2 things that I think we should consider. The World Health Organization says there's universal health coverage, the national health insurance, if the national health insurance can be implemented in the way it is conceptualized, that it will give access, quality, and all those great things that appear in the documents about the national health insurance, we'll be able to deal with some of the deficiencies that Dr. Farid talked about, of a patient going to the clinic finding that there are not enough nurses, that they get tired, they go back home, and they're supposed to take treatment, they can't get somebody to come and support them on treatment and stuff like that. So the national health insurance was supposed to do that. That's one. Two, the issue of funding. We will not have enough money from the government side to support all the community-based organizations that are helping government to implement programs in the community. And this is where we need to advocate for, whether it's the Global Fund for AIDS, TB, and Malaria, or other countries in the world, to put more money on tuberculosis. The amount allocated for tuberculosis is very low. HIV came in, and there was good funding for HIV, and there was a lot of progress that was happening because of good funding. And I think we need to advocate more for funding so that the community-based organizations that Vuyo is talking about, are able to reach more people in the communities. We can do contact tracing, we can support people on treatment, we can ensure that not everybody has to run to the clinic, that we implement, more differentiated form of care. Like the treatment for HIV, it's a lot easier. You go to something that looks like an ATM machine, and you put in your number and you get your medication. We want to get those kind of things for tuberculosis, but all these things require some funding, and the funding that is allocated by government should go to the provinces and the districts and the local authorities. But we need the international community to support funding for tuberculosis for all these programs to reach out to more people.
And that's our program for tonight and for this week. Do join us again on Monday, same time. Have a good night and a great